Hello everybody, my name is Alyssa Peterson. I am one of the Student Success Coordinators down on the second floor. Today we are going to talk about the neurological system, and that's chapter 25 in your textbook. So this is an overview for your health assessment class, just kind of breaking down this chapter and really focusing on common questions that you'll see on tests. And then we'll also kind of in the beginning go over the content, and then at the end go over some test questions and break down those questions and look at the rationales for each answer choice. Okay, so let's get started. So let's start with some anatomy, and let's talk about the lobes of the brain. So first you have your frontal lobe, and that's going to be responsible for all your voluntary movements. So any skeletal actions, it's also going to be in charge of your communications, emotions, intelligence, reasoning, judgment, and behavior. So that is where your Broca's area is going to be, and so that is in charge of your speech. So anytime you have some sort of injury or insult to that area, it's going to affect your speech. So remember, Broca's area, that's in your frontal cortex, frontal lobe, and that is responsible for your speech. Parietal, so right on top of your head, that is your tactile stimulation. So any sort of sensations that you feel, sharp, hot, cold, dull, that area is located in your parietal lobe. Occipital, so back of your head, that is going to be where your reading and comprehension comes from. So it's also where your primary visual receptors are located. So you can actually go blind from a head injury to the back of your head, because that's where all your visual receptors are. There's lots of ways to go blind, and that's actually one of them. And then your temporal on the sides of your head, that is going to be where your Wernicke's area is, and that is responsible for interpreting any sort of auditory stimulation that you receive through your ears. So that's the part of your brain that's letting you figure out what people are saying to you and interpreting any sort of like noises that you hear throughout the day. So here is a cute little picture or drawing that can help you kind of remember those cranial nerves. Most tests aren't going to make you remember the name and the number. They'll give you both of those, but they want you to really understand the function of them. So we'll kind of go through each of these. Another acronym that you can use to remember which cranial nerve and how they go in order. So on old Olympus towering tops, a Finn and German viewed some hops. And so that's going to be in table 25-2 in your textbook. And so we'll kind of go through a deeper dive into each of these cranial nerves and really talk about specifically which one is responsible for what and how do you test each of them. So there's a few that I've eliminated just because honestly they're not on the test. So they're important to know, but won't necessarily be tested on. But the ones that I did put on here, which are the majority of them, you'll see, and they'll show up either on this test or tests in the future. So your optic nerve, number 2. So how you test for that is your Snellen chart, right? Have them stand back a certain amount of feet and see that big E chart, what they can read, the smallest line they can read. This is also where you're going to view the retina and the optic disc. So you need to assess those in order to make sure you're thoroughly assessing the optic nerve. Okay, so then your ocular motor, trochlear, and abducens, so that's 3, 4, and 6. You can assess all 3 of these by having the client move their eyes in those 6 cardinal directions. So up, down, and then kind of make an X. Go over to the left and then up and then right and down, right and up, left and down. And have them follow either a pen light or your finger. And so you're assessing all three of these cranial nerves by just doing that one assessment. So that's a really good test question that you might end up seeing. What is one examination that you can do to test all three of these cranial nerves? And so you're also assessing the pupillary response to light. So you're going to use your pen light. You're going to shine direct light into one eye and then view the pupillary response in that same eye. And that's called direct response. The consensual response is when you shine the light in one eye and you're observing the opposite eye. So your pupil should constrict in both, and that's that consensual response. And then accommodation, that's when you're moving an object closer to the patient's nose and watching for bilateral pupillary constriction. So you bring your pen that's far away from their nose and then slowly bring it into their nose and watch their pupils in both eyes. They should constrict equally. Any sort of abnormal finding is going to be constricted fixed pupils. That's going to indicate narcotic abuse. I'm sorry, there's a typo here, but that's constricted fixed pupils or constricted pupils that are unresponsive to light or accommodation. That is seen when you have lesions on the sympathetic nervous system. So those are things that you want to report and follow up closely with. So moving on to your trigeminal nerve, number 5. This is where you're going to have their client clench the teeth, and the nurse is going to palpate the temporal and vestibular muscles, and we want to note how it contracts bilaterally. So if it's an abnormal finding, you're going to have decreased contraction on one or both sides, or kind of a unilateral or bilateral weakness. So they're not able to use their facial muscles appropriately or with the same amount of force that a normal person would. So since number 5 is your sensory motor reflex, you're also going to be able to do that sharp and soft test on your patient. So grab the point of a pencil and then a cotton ball. Can they tell the difference between a sharp sensation on their skin versus a soft? And then you're also going to test your corneal reflex. So that's where if something's coming at their eye, they're going to blink when you get close to their cornea, that bilateral blinking. So people who have contacts and they put in contacts every day, you're kind of working against that reflex because you're putting your contact actually in your eye, and so you're really having to kind of ignore that reflex. Okay, so number 7, your facial cranial nerve. This is where you're observing symmetrical movement of the face, and you're going to ask them to smile, frown, show their teeth, puff their cheeks out, purse their lips together, raise their eyebrows, close their eyes tightly, doing lots of facial movements, and you want to note, is everything symmetrical? Is everything moving at the same time on both sides of their face? So if they can't do that, that's when we're concerned about possible Bell's palsy. So if one side of their face can't move, or they can't wrinkle their forehead or raise their forehead, we're probably looking at someone who has Bell's palsy. Someone who has a hard time moving the lower parts of their face, they could be suffering from a stroke. So we want to look, like I said, look at that symmetrical movement. If you tell them to do any sort of these actions, can they do it equally on both sides? So next is going to be your acoustic or vestibulocochlear, your 8th cranial nerve. This is where you're going to do your Weber test. Are they feeling those vibrations equally on both sides? Your Rhines test, and this is where you're going to note that air conduction is twice as long as bone conduction. So this is where you're going to be using your tuning fork and noting whether the patient can feel those vibrations equally or hear those vibrations equally on both sides, or if it's unilateral. And so then you can note if there's any sort of sensory neurological hearing loss. So make sure that you know the big takeaway from this is that air conduction is twice as long as bone conduction. So moving on to your glossopharyngeal and vagus nerves, so 9 and 10. So 9, this is where you're going to get your patient to stick out their tongue and say, ah. And this is where you're assessing the uvula and if it rises symmetrically up to the soft palate. Then you know that their cranial nerve 9 is intact. If you assess their gag reflex, if you bring that tongue depressor back into the back of their throat and they gag, they have that gag reflex, that means that their central nerve or cranial nerve 10 is intact. So making sure that you know each one and what it's assessing for. So finally, the cranial nerves 11 and 12, so your spinal accessory is cranial nerve 11. This is when you're going to have them do that shoulder shrug and turn their head against resistance. So place your hand on their cheek and have them turn into that hand. And then can they do that equally bilaterally? Is there any sort of muscle weakness on one side or the other? And then cranial nerve 12, this is assessing the tongue strength and mobility. So can they move their tongue up and down, left to right, and is everything equal and smooth? So moving on to your reflexes, this is when you're going to be assessing all your deep tendon reflexes. You're going to note whether they're hyperreactive or hyporeactive. Hyporeactive is when you're going to get a reaction or no reaction, so you'll rate that as a 0. And this is seen when you have lower motor neuron or reflex arc that is impaired, so such as a spinal cord injury, right? You're not going to get a patellar reflex or a positive patellar reflex from someone who's had some sort of spinal cord injury. Patients that are hyperreactive, so +4 on that 0 to 4 scale, this is going to be it's going to indicate that they have some sort of lesion on their upper motor neurons. And so this is also when you'll see like high cortical levels that are impaired. So you do your patellar reflex and their leg jumps off the table. And so that's a hyperreactive reaction. So if reflexes are diminished or absent for arms, like if you're having a hard time eliciting those reflexes, for an arm reflex, you can have them clench their teeth, kind of distracts them and makes them, loosen their muscles in their arms so that you can get an appropriate reaction. And then if you're having a hard time getting any sort of reflexes in their legs, like if you can't get that patellar reflex and you're just kind of beating their knee over and over and over with the hammer, have them interlock their hands and kind of pull against each other. That's going to cause them to relax their muscles in their stomach and in their lower legs, and then you'll have a better chance of actually getting an appropriate reaction. So if you're going through your reflex assessment and you notice like everything's been hyperreactive, they've been +3 or +4 with all of their reflexes, this is when it should raise a red flag in your mind, and you should also assess for clonus in the patient. So this is when you're going to have them lay down, you're going to grab kind of by their foot and their ankle and briskly push their foot towards the head and hold it there for just a second and then let go. And so as their foot comes down and relaxes, if you notice any sort of rapid beats in the foot as it's coming back down or relaxing, that is a positive sign for clonus. And so typically what you should see is you dorsiflex the foot towards the client's head, you let go quickly, and then their foot just relaxes. There's no sort of like tapping or repetitive beats that are noted with the ankle. But if you do see any of that tapping, then that means that they probably have some lesions on their upper motor neurons. They're at an increased risk for seizures, and they have a hyper-reactive reflex, and that is something that you need to then pass on to your provider. So if we're testing for meningitis or meningeal inflammation or any sort of inflammation, so for meningitis, the provider is going to place their hand behind the patient's neck and flex the neck forward as far as they can tolerate it. So pushing their head down kind of towards their chest. If they start to complain of pain, stiffness, then it's a positive sign for meningeal inflammation. And so they should be able to move and flex their head without any sort of stiffness or pain. If they do, then there's probably some inflammation in that meningeal lining. And that's something that we need to look at further and do some more tests. Another test that we can do to see if they're having any sort of meningitis type symptoms is Brzezinski's test. And so a positive Brzezinski's test, you're going to have the patient, they're going to be flat on their back, and you're going to ask them to flex their neck up and lift up their head. And so if you see and you're watching for reaction in their hips or their knees, and so if they kind of pull their knees up because it's hard for them to pull their head up, then that's a positive sign. That's something that is suggestive of meningeal inflammation. Same thing with the Koenig sign. Again, your patient's going to be flat on their back, and you're going to have them lift their leg up and then push against their leg. So if they start to come off the table and in pain from you doing that maneuver, then that's another positive sign that should be a red flag for meningeal irritation. If there's no pain or discomfort behind the knee as they flex their leg up, then that's normal. That's okay. And then here's 2 links that you can click on and watch someone that actually demonstrate those assessment. And they, I believe, both have positive findings, so you can see the positive findings with that as well. So the different types of gaits, that's always going to be tested on. That's something that you need to know. The cerebellar ataxia gait, this is seen in cerebellar disease, and it's like the classic drug and alcohol. They're intoxicated, they can't walk that straight line. So hopefully these GIFs are working for you, and you can see kind of an example of each one of these as we talk about them. The Parkinsonian gait, shuffle is your key word. Anytime you see a test question where they're stooped, they're shuffling, small tiny steps, then you want to think Parkinson's. So there's 2 examples here of what those look like. So other gaits that you'll need to know, the scissor gait. This is a stiff, short gait. Their thighs kind of overlap with each other like scissors. You'll see these in patients that maybe have partial paralysis, that have a real hard time keeping their balance, keeping themselves upright. They'll probably need some sort of assisted device as well to help them walk. And then this is your example for your scissor gait up here. The spastic hemiparesis, this is when you're going to have arms that are flexed and held close to the body, and you'll kind of have that toe drag. The leg moves in a circular motion to kind of bring it up and forward. So a lot of patients that have had strokes will have a gait like this. And so making sure that you know the difference between each one of them and what causes it, right? So stroke is when you're going to see patients that have this type of gait. The foot drop, this is where they can't walk on their heels. And you have this with the lower motor neurons, if there's some sort of injury to that. So they kind of bring that knee as high up as they can, and then their foot just kind of slaps down on the ground. They have no control. They can't walk kind of like heel to toe. That foot just kind of drops down as fast as it can. Posturing for unconscious patients. So you need to know the difference between Decorticate and Cerebrate. So Decorticate, this is when your elbows are flexed internally. Your knees rotate internally, and then this is seen with cerebral cortex damage. So if you can kind of think Decorticate, they have the C's, and then your arms look like C's. Everything's kind of pulled inward. Like I said, this is problems with the cervical spine or cerebral hemisphere. And then Cerebrate, this is when the elbows are extended with the wrists kind of turned out. And then this is seen with lesions on the brain stem or at the midbrain or upper pons. And so if you think Cerebrate has all those E's, your arms look like E's. They're turned out. So know which one looks like what, how your patient is going to present, whether they're Decorticate or Cerebrate. So now we have some practice questions. So with each one of these questions, we're going to read the stem of the question. We're going to look at our answer choices. We're going to pick out keywords with in the stem of the question to help us better answer these. We're going to eliminate some of the answer choices that we know are not right, and then we're going to pick our correct answer and read the rationale. So a nurse is caring for an elderly client with right side hemiplegia and expressive aphasia. Which deficit should the nurse expect to find in this client? So are they going to have trouble remembering familiar faces, inability to recognize familiar objects, rapid speech with no meaning, or slow speech with appropriate meaning? So we want to know, what are we going to see in a patient that has expressive aphasia and right-sided hemiplegia? So even if I don't know what this means, I should know what aphasia means, right? That has something to do with speech. That's something to do with they're having a hard time communicating. So if I know this aphasia means speech, I can probably eliminate A and B, trouble remembering familiar faces or inability to recognize familiar objects. Doesn't really go along with aphasia. So basically, what is aphasia, right? Rapid speech with no meaning or slow speech with appropriate meaning. So if you have any sort of type of Broca's aphasia, that's when it still makes sense. You're still able to understand what they're trying to say, but it's very slow. And so the correct answer is actually going to be D, slow speech with appropriate meaning. Rapid speech with no meaning, that's when you're going to have that Wernicke's aphasia, right? That has more to do with, so these patients will have rapid speech, but they just don't understand the words, and they don't understand that they're kind of putting in nonsensical words into their sentence. It's like they're having a full conversation, but it just doesn't make sense. There's just kind of jumbled up words, and it doesn't necessarily answer the question that you've asked. People who've had Broca's aphasia, they are slow in speech. It takes a really long time to get those words and sentences out. It's hard for them to make their mouth move into those shapes that they need to make in order to make those sounds and words. But it makes sense. It makes perfect sense what they're saying. They're answering the question appropriately of whatever you've asked them. So this is the most appropriate answer for that expressive aphasia. So next question, what should the nurse assess to test the function of the parietal lobe? So remember, parietal lobe, that's going to be on the top of your head, and what is that in control of? That's basically what this question is asking. So is it the ability to read, communication, tactile, stimulation, or impulses from the ear? So if we can kind of go through each one of these, the ability to read, remember that's going to be on your occipital, the back side. Kind of think you read with your eyes and your vision is on the back side of your head. So that's the occipital lobe. Communication, we just kind of talked about, that's your Broca's area and that's in your frontal lobe. Tactile sensation, that's going to be on the top of your head. So probably parietal, but let's just make sure, let's read all of our answer choices to be sure. Impulses from the ear. So remember, ears are on the side of your head. Temporal lobe is responsible for that. So the right answer is tactile stimulation. So make sure you know all the lobes and what they're in charge of. All right, so next question. A nurse cares for a client diagnosed with cranial nerve 3 disorder. What should the nurse expect to find in this client? So keywords, cranial nerve 3 disorder. Something's gone wrong with his cranial nerve 3. So what is an expected finding with someone who's had impairments to their cranial nerve 3? So let's go through each answer choice again. So we got to remember what is cranial nerve 3, and that's our ocular motor. So let's go through each one of these. The inability to close their eye. And the loss of visual fields, drooping of the eyelids, or swelling of the optic nerve. So let's go through and answer A. So that is actually going to be inability to close your eyes. That's your facial nerves, the muscles surrounding like your eyelids. That is your facial nerve is responsible for that. Loss of visual fields, that is going to be your optic nerve, so cranial nerve 2. This is also cranial nerve 2, swelling of the optic nerve. And so our best answer choice is actually going to be C, drooping of the eyelid. That is your ocular motor nerve. So it can get kind of tricky because you can kind of get it down between A and C, and if you go back and look at your table on 25-2, under facial, that last, under ocular motor, the third one, part of the function, it says elevates eyelids, and so that's why C is most correct, because it's that involuntary movement of your eyelids, the inability to close your eyes. If you look under facial, that is going to have more to do with you actually consciously closing your eyes, closing your eyelids. But if you just have a drooping eyelid, that's going to be responsible, your cranial nerve 3 is going to be responsible for that. Okay, so what action by the nurse demonstrates the correct technique to use the reflex hammer? So basically, how do we use our reflex hammer correctly? We're going to tap the tendon gently to avoid pain and tingling, use a rapid wrist movement to strike the tendon, instruct the client to tense the muscles before striking, or strike the tendon, then palpate for a response. So you can kind of act this out a little bit, right? and go through each answer choice and do answer how based on how it feels and how you're acting it out during the test. So tap the tendon gently to avoid any pain or tingling. I probably am not going to do that because it's not going to elicit a good enough response for me to accurately grade what sort of reflex they're having. Use a rapid wrist motion to strike the tendon. Yep, I remember doing that. I have to kind of do it forcefully, not too hard, but hard enough to where I'm going to get a good response. But let's keep going to make sure that we don't skip something that might be correct. Instruct the client to tense the muscles before striking. Well, that's not right. I remember going back and looking over previous slides, trying to give them techniques to relax the muscles so that I can get a good response. So making them tense them is probably not appropriate. And then strike the tendon to palpate for a response. You're not palpating a response, you're visualizing a response. How much does their arm or leg or elbow jump off the table? So the correct answer is B. So next question, a nurse performs a neurological exam on a client who sustained an injury of the spinal cord. Which finding should the nurse expect when stroking the bottom of the client's feet? So are we going to see plantar flexion, fanning of the toes, dorsiflexion, or flexion of the toes? So we need to remember what is an appropriate response or what is an anticipated response for someone who's had a spinal cord injury. So if they have fanning of the toes, that is a positive Babinski reflex, and that's really only seen in newborns. Dorsiflexion, that's kind of part of their range of motion, so not necessarily seen with someone who's had a spinal cord injury. Flexion of the toes, that should be a normal response for someone that's had someone who's stroking the bottom of their feet and has not had a spinal cord injury. So that kind of leaves us with plantar flexion. And so that is what you're going to see with any sort of spinal cord or brain injury, because it's going to cause that abnormal posturing in the client, right? This includes plantar flexion when the feet are stroked. So you're going to see those toes kind of point down or inward, and that is what we would expect to find with someone that's had a spinal cord injury. Okay, select all that apply. A client presents to the healthcare clinic with reports of difficulty swallowing. Which cranial nerve would provide the nurse with information related to the problem? Select all that apply. So which cranial nerves are responsible for swallowing, and if someone had difficulty swallowing? So trochlear, I know that's number 4. That's related to motor. Abducens, that's 6. That's also motor. Glossopharyngeal, that's 9. That probably has something to do with swallowing. Hypoglossal, that is 12. Again, probably has something to do with their mouth or with swallowing. Your vagus, that's that gag reflex. Probably has something to do with swallowing. And then spinal accessory, that is 11, and we know that's probably not having to do with anything with swallowing. So the correct answers are C, D, and E. So remember, trochlear, that's going to be your eye muscle and controls that eye movement. Abducens is the lateral eye movement. Anything with glossopharyngeal, vagus, so that's all going to be with swallowing. So people that are going to have difficulty swallowing, CVA patients, Parkinson's, myasthenia gravis, or Guillain-Barré patients, they're all going to have difficulty swallowing. This is responsible for your neck and shoulder muscle movements. So your correct answers are C, D, and E. When performing an assessment of the nervous system, it is most appropriate for a nurse to complete in which sequence. So how are we going to do our nervous system assessment, and what's the appropriate order? What are we going to do first, second, third, and fourth, and last? So if you can kind of look at these answer choices, motor, cerebral, sensory, cranial nerves, and mental status. Reflexes, sensory, motor, cerebral, cranial nerves, and mental status. Cranial nerves, motor, cerebral, reflexes, mental status. And then the last one, mental status, cranial nerves, motor, cerebral, sensory, and reflexes. So you always want to assess the nervous system from level of higher cerebral integration to lower reflexes. So the first thing that I always want to assess is their mental status. I want to know, are they oriented to person, place, time, and situation? So with all of these answer choices having mental status being last, that's inappropriate. So that's a big clue. If you have test questions where it's like all three of them are the same and there's one that's kind of different or off, then that's probably your right answer. So the correct answer is mental status, cranial nerves, motor, cerebral, sensory, and then reflexes. So again, you're going through the nervous system of higher cerebral integration to lower level reflexes, kind of going head to toe, literally. So next question, a client presents to the healthcare clinic with a 3-day history of fever, chills, neck pain, and stiffness, and a headache. The nurse observes the elevated temperature of 102.5 Fahrenheit and pain with rotation of the head to side, and decreased ability to flex the head forward. The nurse recognizes these findings as most likely the onset of an infection process. Or which infection process? So our answer choices are spondylitis, bursitis, meningitis, or arthritis. So this one should be pretty obvious. We got fever, chills, stiff neck, and neck pain. That's going to be your big keywords. These are all signs and symptoms of meningitis. Spondylitis, that's actually an inflammation in the vertebra. Bursitis, that's inflammation in the bursa, the small sacs, or the synovial fluid in the body. And then arthritis, that's inflammation or infection within your joints. So that stiff neck is key in order to diagnosing meningitis. What instructions should a nurse give a client when having trouble eliciting a response from testing the patellar deep tendon reflex? Place your hands together, lock your fingers and squeeze. Close your eyes and imagine you're somewhere else. Tighten the thigh muscles of the opposite leg, or clench your teeth and breathe slowly and deeply. So remember, we want them to kind of relax those abdominal muscles, relax the muscles in their lower half and their torso and their lower legs. So we can eliminate C because that's going to do the opposite. Clench your teeth and breathe slowly and deeply. Close your eyes and imagine you're somewhere else, or place your hands together, lock your fingers, and squeeze. So if you can kind of remember back to my slide, A is actually the most appropriate thing that you're going to do in order to get them to relax those muscles and get a better response for their patellar deep tendon reflexes. This might work. I mean, imagine that you're somewhere else, clench your teeth and breathe slowly and deeply. That's for your any sort of upper arm reflexes. You want them to clench their teeth. But the best answer choice to get them to really make sure they relax their muscles is A. Okay, when assessing a client's coordination by asking the client to touch the nose with the finger, what should the nurse keep in mind about the client's movements? The dominant side will be more coordinated than the non-dominant side. Most clients will hesitate before touching the nose to check their position. Uncoordinated movements can be expected in the elderly. As the clients repeat the maneuver, movements will get less accurate. So what is an expected finding, or what should we keep in mind about how the client moves when we're touching nose to finger? So clients will hesitate before touching the nose to check their position. No, it should be smooth and coordinated all the way through. Uncoordinated movements can be expected in elderly clients. You can kind of expect slower, but not necessarily uncoordinated. So it should still be coordinated no matter the age. So we can eliminate that one. As the client repeats the maneuver, movements become less accurate. No, they should remain accurate no matter how long we're repeating the maneuver or proceeding with the test. So the correct answer is you will be more coordinated with your dominant side than your non-dominant side. So you want to take that into account. If they're right-handed, they're going to be probably a little quicker, a little faster at it. They should still be, coordinated, but might be a little bit slower with their non-dominant hand. The nurse assesses the client who presents to the healthcare clinic with suspected Bell's palsy. Which findings should the nurse anticipate on examination? So keywords, Bell's palsy, and anticipated findings on examination. So basically, what does Bell's palsy look like? We're going to have drooping of the eyelids, inability to wrinkle the forehead, paralysis of the lower lip, or limited lateral gaze of the eye. So drooping of the eyelids, if it's bilateral, that's really more seen with like weakness in the muscle and not really associated with Bell's palsy. Paralysis or inability to wrinkle the forehead, so that is a sign of Bell's palsy. I remember going back in our previous slides, they have a hard time moving their facial movements, right? Raising up their forehead, wrinkling down their forehead, puffing out their cheeks, things like that. But let's make sure, and we're reading all of our answer choices. Paralysis of the lower lip, it's not really seen in any cranial nerve disorders. And limited lateral gaze of the eyes. Doesn't really have anything to do with Bell's palsy. So your correct answer is B. D is actually indicates an increase in intracranial pressure. So they're unable to kind of move their eyes or their gaze from laterally, side to side. So B is the correct and most appropriate answer choice for Bell's palsy. Remember, think Bell's palsy, it's kind of like the upper face. This lower lip paralysis doesn't fit that. Okay, just a couple more questions. A nurse observes a client's gait and notes that they're to be a wide, based, and staggering. The Romberg's test results were positive. The nurse recognizes that this is what type of abnormal gait. So is it cerebral ataxia, spastic hemiparalysis, foot drop gait, or the Parkinson's gait? So I remember that Parkinson's, they have that shuffle, and nowhere in here does it say shuffle. That's not one of my key words. The foot drop, that's when they lift up their foot and knee up high, and then with each step they slap their foot down. So don't see that anywhere. The key word here is wide, based, and staggering. So we kind of got it narrowed down to A and B. Spastic hemiparalysis, that's when you're going to have that like circular motion of bringing the leg forward. And it's not necessarily staggering. It is kind of wide based though, but their arms are going to be up close to their body, and they kind of drag that toe, moving it forward in a circular motion. And then the cerebral ataxia, that's when they have either like drug or alcohol intoxication. So if you can kind of link that and think wide base staggering, that positive Romberg's test is a clue, they have the cerebral ataxia gait. A nurse is working with a client who is a victim of a gunshot. The client has increased pulse rate, pupillary dilation, and is clearly in distress. The nurse recognizes this fight or flight response in the client and understands this represents the action of which of the following? So is this the somatic nervous system, the parasympathetic nervous system, the central nervous system, or the sympathetic nervous system? So I put this question in here on purpose because sometimes this is what happens to y'all when you sit down to take a test. You kind of get in that flight or fight mode. And so let's go through each answer choice. The somatic nervous system, so this is where all your conscious or voluntary activities are. The autonomic nervous system, that's your involuntary or unconscious activities. So somatic, that's you purposely getting up to walk across the room to go get a glass of water. The autonomic nervous system is your breathing. You don't have to think about that. Parasympathetic nervous system, that is what maintains your normal body function. That's you taking that big deep breath before you take a test, calming down, getting back into that normal body function. Central nervous system, that is what encompasses your brain and spinal cord. And so our only option left is sympathetic nervous system. So that is your fight or flight. That's what's activated during stress. So any sort of digestion stops, your pupils dilate, so you can run away from the lion or the gunshot person that has the gun. Your pulse is going to increase, and this is when you kind of get into that fight or flight mode. And so like I said, sometimes y'all get into this when you just go sit down to take a test, and you're not going to be thinking clearly, you're not going to be at your best when you're in this sympathetic state. So try to take slow, big, deep breaths, calm yourself down, and get yourself back into the parasympathetic, and then you can continue on with your test. And sometimes you kind of have to do that a couple times during the test, right? If you kind of feel yourself getting a little anxious or notice that your heart's racing, try to slow yourself down and force yourself back into that parasympathetic state. Okay, so I think this is our last question. A nurse is conducting an assessment of an elderly client's nervous system. The client mentions that he has experienced decreased taste and scent sensations recently. Which of the following should the nurse do at this point? So ask the client whether he has experienced a head injury recently, record the findings, and proceed with the assessment. Ask the client whether he has experienced sudden numbness or weakness in his face or arms, or perform the Weber test on the client. So sometimes with test taking, it's just as important to know all the crazy abnormals and the things that can kill you. It's just as important to know just what is normal. So your key word here is elderly client. He's experienced a decrease in taste and scent sensations recently. So it's not long term, it's kind of happened recently. So what should we do at this point? And the correct answer is just to record this as normal and move on. So sometimes there's not like a why or a big reason behind what some of these things that patients are experiencing. Elderly clients are always going to have slowing or decreased sensations, and so or response times, and so that's something that you want to keep in mind when you're answering these questions. Look for that key word where it says elderly. More often than not, then it's just kind of like a normal finding for those elderly patients, because everything tends to kind of slow down as you get older. You're not quite as sharp with your taste buds or your scent receptors. You don't smell as well as you get older. So that's just a normal finding. And you're going to record that and move on. So that is the end of this presentation. I hope this was helpful for you. If you would like to come by and make an appointment and we can go over some more stuff that's in detailed as far as content, if you need that, we can also review test questions on previous tests that you've had. I really encourage you to come and review your tests before your next one. That way it's fresh on your mind, and then you can really review and look at those rationales and maybe why you got some of those test questions wrong. So if you want to make an appointment, you can email me. You can also go to the Student Success website and make an appointment there there's a link to our bookings page. You can always call. That's my office number right there. And I hope, like I said, this was helpful for you. Please call or come by if you have any further questions. Have a good day.